Oh, we're so excited that you're here, Mary from Perfecting Peds. I feel like it's one of those things where I had a pharmacy question, and then it's like when you learn a new word, and then all of a sudden, like I kept having pharmacy questions. And what you and Perfecting Peds are doing is so amazing. So we're really excited to learn from you today. I have a lot of questions.
Thank you. I'm so happy to be here. And like it's kind of crazy because like Bree was on our podcast a few months ago and it was just like a weird like you reached out to me through Jenna because you know Jenna, and then
Yeah.
I found Bree because I worked on a paper with Brooke, and then Brooke brought Bree on. So it's just like the world is so small, but it's honestly so beautiful. Like I love how like interconnected and intertwined we can be, and honestly, SLPs are my favorite. So I'm happy to be here. Thank you for having
Oh.
me. And I guess a little bit about myself. I was like, I forgot that part. So my name is Mary Vuong. I am a pediatric pharmacist by trade, but I'm currently chief of staff for Perfecting Peds, and I have a background in nutrition. So that's probably how this all melts together really well.
And I think it's important because I know for me as an SLP, I don't collaborate with pharmacy very much. And the more that I've been collaborating with you guys, the more I'm like, oh my gosh, this is really, really, really important. Could you tell us a little bit about Perfecting Peds and how it's different? Because there really isn't Jenna. So can I give a little background about Jenna? Okay. So I met Jenna a few years ago around the time that I was starting my private practice. And a friend introduced us, a mutual friend, and she was just like one of those people who was ready to take over the world. And you could talk more about the Perfecting Peds journey, but the way that you just shared that all of us are so connected, it was just like today was meant to be. And I feel like we could help so many families today with the things that you're going to share because so many of the children that we see with chronic illness or our complex kiddos, they're on so many medications. And there are so many ways that we could streamline their care and make it better. So could you tell us like that outpatient space that Perfecting Peds is in and how it's different?
So the outpatient space is really different. I spent 6 years of my life working in a hospital where we had complete access to SLPs all the time, and I think like feeding and swallowing was like what top of our list usually before discharge, especially for like little kids and new diagnoses. So I was so used to having like an SLP at my fingertips, and we would do like all kinds of different swallow studies. We would ask about the different consistencies, and most of these kids had G tubes and things. Now that we're in the outpatient space, it's quite different. So Perfecting Peds is the first company to bring the pediatric pharmacists outside of the hospital. There's about 1,900 pediatric pharmacists in the United States, which is kind of crazy to think of. It's only about 0.5% of the whole population of pharmacists practice in peds. And if you think about how many children there are, it's a little scary to think that not many people are specialized in this. So Jenna Quinn is our founder, and she worked at a bunch of hospitals in Camden, New Jersey. She worked at Cooper University, CHOP, and she realized that there was something wrong because a lot of these kids that were like complex kept like being readmitted, and there was a reason. And one of the reasons she postulated was because they weren't being followed by pediatric pharmacists outpatient. Inpatient, if you've ever worked with a pediatric pharmacist, we're on the care teams, we're rounding with the teams, we're pretty much at the disposal of the care team all day for any sorts of questions. And we see a holistic view of the patient. So we're the person that sees all the medications and not just like the specialist sees this, the neurologist sees this, like the pediatrician will only touch this. The pharmacist is the one that has to like see the whole picture. So what she postulated is if we brought this pediatric pharmacist to the outpatient space, we'd have better outcomes. So she started off first just in like the long-term care facility space in New Jersey, and she took care of patients in 3 facilities. And she was like, yeah, I think we are making a big change. So she put this to practice and actually did a research study, which was published in the Journal of Pediatric Pharmacy and Therapeutics in April of 2024. And the study found that in 102 patients, by having like that one pediatric pharmacist take care of them outpatient, they were able to reduce medications by 15%, readmissions by 44%, and they were able to save the facility about like $1.2 million for 102 patients, which is kind of wild. So then she brought this data to health plans. And the first health plan that we contracted with was Health Partners of Minnesota. We're also with Geisinger in Pennsylvania. We take care of a lot of Medicaid patients, and we're kind of like working our way through the country. So she contracted with these health plans and told them like, hey, if you give me your most high cost, high needs patients, I'll be able to save you a bunch of money and I'll also create better outcomes. So just by like having that specialist take care of a patient and see them as a whole patient instead of just like a silo of this is your brain, this is your stomach, these are your lungs, it'll definitely help the like standard of care in the country. So how I got involved with Perfecting Peds is my mentor, Gabby, reached out to me and was like, "Hey, you'd be perfect for this. Like maybe you should look into this." So I reached out to Jen on LinkedIn, as ballsy as I've ever been in my life, and I said, "Hey, you should hire me." And she was just like, "Oh, normally I don't respond to these messages because now that I see her LinkedIn and I see how many messages she gets in a day, like I understand." But she was like, "There's something about you that made me want to talk to you."
Mm.
And like that's kind of like how the process started. I started off as a contractor and then worked my way to like clinical pharmacy manager. And then about 6 months ago, I was switched over to chief of staff. So I do a little bit of everything. I see patients, do the marketing, just a lot of the day-to-day operations. And we're currently working on building our like product, so our little EHR right now. So it's been a fun, wild ride at Perfecting Peds.
It's grown really fast.
That's
Yeah.
awesome though, because I feel like as, an SLP who's in the outpatient or in the community side, like it is very rare that we get the interactions with the pharmacist or that the even like not just us reaching out to the pharmacist, but the families even being aware that they can have a conversation with the pharmacist that they're working with now. Because I think it is one of those things like they were in the hospital and it was so closely tied to the team that when they leave, I feel like sometimes when I tell families like, oh, I know your child's on this medication and you feel like it may be affecting XYZ, like have we talked to the pharmacist about it? Or like I'm having trouble getting my child taking this medication. Like, well, did you talk about could we add flavoring or could we use it in a different form or could we and like not even being aware that that's the conversation like with the pharmacist that we should be having versus like going back to their, pediatrician to ask that question. It's like, well, actually, the pharmacist is definitely the expert in this situation.
I think it's like a cultural thing too, just because in this country we're used to like doctors prescribing and everything just coming from the doctor. Whereas in other countries, like I went to a conference, it was funny enough, a conference in Africa during pharmacy school, and just the model in different countries is interesting. So in England, I think even to just get like a simple Tylenol or something, you have to see the pharmacist, and the pharmacist has to like go through the check boxes. So it's really interesting now with Perfecting Peds because we've built this relationship with a lot of our families where if like one of the caregivers knows, oh, we're starting this medication, they'll reach out to me for an appointment and then they'll tell me like, we want to start this medication. Can you check all the boxes to make sure it's okay? So like with my pediatric pharmacist brain, I'm thinking, is the dose okay? Is it indicated? Is it safe? Will it be effective? But then also on another level, does it interact with their medications? Does it interact with their diet? Because that's something we're always asking, like what kind of formulas are you on? What kind of consistencies? Like what's your diet like? If they have feeding tubes, if that interferes, if it'll be like given via G tube or J tube. And then we also think about pharmacogenetics. So we do pharmacogenomics panels on almost all of our patients. And then I also always check it across that. So it's like when a parent comes to me with one question, there's like 10 different check boxes that we will go through just to make sure that everything's okay.
Is I'm not even going to say it right, but is that the way that you metabolize medication? Okay, so Jenna, when I first met her, she was actually helping me with my mom because my mom is on like a million different medications. And one of the questions that she had me ask her provider was like, have you guys looked at how she metabolizes these medications? Because we just could not get things to balance out for her. And it was a game changer. But I don't know how often is that really being done in pediatrics? And can you explain a little bit more about what it is for people?
Pharmacogenomics is a pretty simple panel. It's like, it's cutting edge and it's new right now. Everyone's trying to like make it just the standard of care. But Cincinnati Children's is actually like the pioneer. I think they started their program in 2005. And basically, what it is it's usually a cheek swab where you're able to gather genes and then it gets sent off to a lab. The lab will then check the genes against like the typical genes that would break down medications. And it'll tell you like, you will break down this medication faster than the average person. So you'll need a higher dose, or you'll have more side effects to this medication because you break it down slower. So it'll sit in your blood for longer. So it really just brings together like personalized medicine. And I honestly love that we do it because it is really cool to have this little PDF, and it's kind of like your 23andMe, like your little personality test of this is how medications work with my body.
That's really cool. And this is like, this is me obviously not being a pharmacist, but that makes me think of how like some people metabolize like caffeine really quickly and can drink like multiple cups of coffee a day. And then there's like me who drinks one and is like, I'm good till midnight. Like it just like stays in my system. That's why I don't drink coffee. But I feel like that's like a good comparison for people. And because like the way we metabolize like so many things is very different, that it's wild to me that like it took until 2005 for that to even be a conversation. Because like of course if we metabolize like foods and things like caffeine and different things differently, that like medications should be part of that conversation too. But I also think other side note is that knowing that like they started these conversations in 2005 and we're now in 2024 and it still isn't like the standard of care everywhere just shows how long it takes for like research to reach practice and for like things like that to happen, which is just a whole nother interesting conversation. But you know, it's exciting to know that that's coming about and that you all are using that with a lot of your patients, because I could see that being just such a game changer for some
And
kids.
you actually brought up like an idea in my head. I'm like, I wonder if there's a panel out there that looks at how you metabolize different foods, because I feel like that would be really interesting to know as well.
Yeah, for sure. Because there could even be some like cross interaction there, right? In terms of you're like, okay, make sure to take this medication with a food and
Yeah.
like,
Oh.
metabolize one at a different rate than the other. Like, how could that potentially play
Hmm.
a role?
I
Yeah.
was like, let's open a lab.
Yes.
I have plenty of Q-tips. We can gather our cheek swabs.
Yeah. We'll just start by swabbing each other and then we'll
Yeah.
go we'll go from there.
And it's covered too by Medicaid, no?
Yeah, it's covered, and some states mandate it. So in Pennsylvania, it is, I believe, one of the mandates that everyone should have it. And like the hospital where I worked started a pharmacogenomics program as well, and they wanted to make it the standard of care. So they were hoping that like by the time the program was like up and running, that every baby like born or like any child admitted would have it already set, and it would be a part of their like just health record. Like this is what it is. I think an important thing to note is that is cool to have it, like when you're born to have the pharmacogenomics panel, but your genes kind of change after you're two when you're fully developed. So then you would have to be like re-swapped at that point.
That's good
Wow.
to
I would,
hear. Yeah.
yeah, I would never guess that.
No,
I
that's
Yeah.
think
so
everything
cool.
matures by two, so then you have to like redo it.
Okay. Okay. And is this something that like say a family needs to get it redone after the age of 2, is that something that they can talk to their pharmacist about? Is it something they talk to their physician about? Is it something that they like go back to the hospital for? Like who typically is running those tests or labs? Like is it something that's just done, like they just go outpatient to see their provider and they can send it off? Or how does that part work?
I think it depends on, I think the state that they're in, just because like some people are more informed about it than others. But I think it's just a matter of asking somebody, and then somebody will lead you to the right place. And it depends a lot on like the different collaborative practice agreements and things that people have based on who can order it.
Hmm.
But I would ask your PCP and have your PCP like kind of
They'd
triage
probably
from
be
there.
able to guide that. Yeah, the connections of care. Cool. Very cool.
The other crazy thing that I learned from Perfecting Peds is how frequent med errors happen.
Yeah, it's kind of scary. I mean, but it's not that it's the basis of our business, but it is like we're here to help prevent med errors, and you'd be surprised just how many errors can happen just from like not knowing what things are used for. So a lot of the parents that we like talk to aren't super health literate, so just like nobody took the time to just explain to them like they're different inhalers. So I think I met with a patient once that they were taking three kinds of inhalers and they're all the same thing because the parent didn't know that the nebulizer, the and then the two inhalers they were taking were all like steroids. So like at home they were getting one inhaler, it was like blue, and then at school they were getting like the orange inhaler, and then at night they were giving the nebulizer, and it was all the same like variations of drugs like budesonide, fluticasone, like all things that did the same, but it's just like nobody took that time to like just explain, oh, these are all the same, we're switching you from a nebulizer to an inhaler, make sure to use the orange one and throw away everything else before you start it. And then there's no communication to the pharmacy, so they're continuing to fill it and there's no communication back to the office, so they're continuing to refill it. So it's just like a Swiss cheese model where if someone just took a second to explain, it would have prevented this med error. And like one of the side effects of taking too many steroids is like growth suppression, but then there's also thrush. So then this child, mom was like, yeah, I don't know why his mouth is always fuzzy. It's like this weird white fuzz all over it. And it was simply because like there was a med error that happened because there was some like leak in the communication. But it happens quite often. It's actually a 1 in 3 chance of a med error happening in a pediatric patient. And it kind of makes sense because if you go back to like what I originally said, not many people have that much education on pediatrics, and it's kind of scary because we are all pediatrics at one point. We all grew up and we were all children. So like in school, I never really had the chance to have like a pediatric elective or class because my school didn't offer it, but they did offer like a rotation block. So I did take like 4 rotations in pediatrics, and that's where I really like gained the love for it. But most people aren't fortunate with like that much training in peds. And then in like medical school and stuff, you don't really get, I think maybe people get like a lecture or a block, but in the grand scheme of things, it's a tiny portion of their education that's devoted to pediatrics. And if you really wanted to learn more about pediatrics, you'd have to specialize in it. So it's just such a very like underserved population. So there's not much research in it. I think we found that 85% of indications for pediatric medications are off label, which is a little bit scary as well. So that means that like it wasn't studied for a pediatric patient, it was extrapolated off of adult data. So that's like another place where there's a lot of med errors. And then pediatric medications are just so different. So for an adult, you hand them like 1 tablet and it's fine. But for a pediatric patient, everything's based on their weight. So you're really calculating each individual dose. And like how I would always explain it to my residents in the hospital was like, okay, you are admitted for an infection. I'm just going to give you this IV bag or this 1 tablet, and that's your dose. But for a pediatric patient, that IV bag had to be further diluted. It had to be calculated and drawn up to the exact weight of the patient. So it would come in a patient specific syringe every day. Or at the same like if it was an oral medication, instead of just being able to give 1 tablet, you would have to either find an oral solution or like compound a suspension or crush a tablet and have instructions on how to like dilute, and it's like a patient specific dose. So it just takes so much more detail. So with all those little details, there's way more room for mistakes.
When you're talking about crushing a tablet and the different things, I don't know if other people would be interested in this, but like I geek out about this and want to learn more. When families are saying like, "Oh, we can't get this medication because it's compounded," or I just talked to a friend this morning and there's a little girl. This little girl is in hemonc and she's being treated for cancer, and she had to stay in the hospital longer because they couldn't get her medication was only in the hospital. She couldn't get it locally outpatient. They would have had to drive to like Long Island, and I'm in New Jersey outside of Philadelphia. So just things like that, like why are certain medications not available? Why do certain ones have to be compounded?
A lot of it is because of the research. So there's not that much money in like funding pediatric research. So a lot of times with like drug companies, it's easier to get something to market also for adults. So that's probably one of the reasons why it's not available in an oral solution. You have to go through like way more parameters to make sure it's stable and that it like stays fine. There's refrigeration and all these like storage things that are so different with liquid medications. And then one of the reasons why she probably couldn't get it at home either was because it's a chemo, so it's probably hazardous. So there's like all these different parameters on like nursing requirements and like requirements for the family if they were to give it. So sometimes that just ends up being like what happens. And like I always freak out because like some of the kids are on seizure medications that are also hazardous. So then sending them home with the right instructions on how to manipulate it. Like let's say they need to cut it. Well, the family needs to know that they have to wear gloves, they have to make sure that they are protecting themselves because some of these medications can be like teratogenic or can be carcinogenic if they're open. So like just little things like that are good counseling points. So it's always great to just like have that pointer to ask a pharmacist before telling a patient to like manipulate a medication.
That's such an interesting, it's just so interesting to learn about, but it also makes me think like going back to our conversation about like health literacy and things like that as well. And so you have to like be very, very clear and like, probably provide education in multiple different ways to make sure that a family like truly understands how to manage that medication, manipulate that medication, and like understanding that like this isn't like, oh, well, we're just in a hurry today, so I'll just like, open it and not worry about like, no, 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 you have to go through that whole process. And then it just makes me think about also like for some of our families, how just the added difficulty and added burden of some of those things as well that they then have to use in their preparation of their day.
Yeah, thinking of like health literacy, we also think of like social determinants of health. So a lot of times the compounded medications, ironically, are so expensive, or because it's compounded, the parents have to pay out of pocket. So sometimes, like as a clinician, you have to think like, okay, their hospital stay is covered, but this medication would cost a lot of money outpatient. Like, what should we do for this patient? So it becomes like an ethical thing sometimes too, where you're trying to help them afford it. Unfortunately, compounded medications usually aren't covered by insurance. So then, as a pharmacist, you kind of have to get creative. Like, what are ways the family can compound this at home? I actually had a patient with H. pylori the other day, and insurance would not cover the oral solution for the flagyl. And like flagyl, if you've ever had it, is the worst tasting medication ever. It just tastes like metal. And the oral solution is a little bit better, but it was $600. The family clearly could not afford it. And we had to get like really creative with that. So we had to like think of ways to like crush it so that it was more like palatable for the kid. So one of our tips and tricks with that is chocolate usually is okay and it doesn't interact. We would stray away from a lot of dairy because dairy interacts with a lot of medications. And then the other medication that insurance wouldn't cover for them was like Nexium or esomeprazole. That usually comes in packets, but insurance would not cover it. So then I had to get creative and I was like, wait, I think maybe we can make them like a cheaper solution with like omeprazole. So like they could put the omeprazole sprinkles into applesauce and give it that way. If she doesn't tolerate that, then you could also tell them we could also tell them to dissolve it with a little bit of sodium bicarb or baking soda, and that helps degrade the pellets and makes it into like literally a liquid. So just like knowing those little tips and tricks, I think will help in those situations where the family's stuck at the hospital because things aren't covered.
That makes me think of the patient that I asked you about, Mary. So I had reached out because I had this little guy who he has an NG tube and he's on thickened liquids. And very quickly, once he was on thickened liquids, he started taking much more PO because wow, he wasn't aspirating. Cool. So we got to a point where we could try to pull his tube and see how he would do orally because he was taking a lot of days, he was getting that full volume. But the meds were the tricky part because the meds were still going through the tube and we didn't know how to, if we could thicken the meds or what that would look like. And so I had reached out to you and you had given me really, really helpful advice about those two meds that he was on and how you would recommend thickening them. And one of them was omeprazole.
Yeah, I feel like there's so many creative ways, but you kind of have to do a deep dive on things. We definitely never recommend like commercial thickeners, like Simply Thick and things like that for medications, because they can alter the way that these medications are absorbed. But most often, like food, like applesauce is usually a good one. I've done a lot of meds in ice cream. So one of my favorite things that we've done was for an autistic child who was so scared of the toilet that I think he didn't go to the bathroom for like 2 or 3 months. So he was literally like filled to the brim with like hardened stool, but he hated the way all the laxatives tasted. So one of my attendings was a resident, I think, at Boston Children's, and they did something called the chocolate bomb. And we didn't, I think we asked him and he didn't like chocolate ice cream, so we had to do a vanilla bomb. So what we did was that we mixed lactulose, which has like kind of a minty flavor, into the vanilla ice cream. So that's like kind of the osmotic, like the wetting laxative that would make his stool softer. And then we took Senna chocolates and we sprinkled them up top. So it kind of like looked like the sundae. And because it was like masked and it looked okay, he ate it and he actually was able to stool. So a lot of times we find like really creative ways like that or like mixing things in the formula. I've had to like mix phosphate binders into formula, like decant it to take out the gel and like give it that way just for a patient that could only tolerate it through the formula. So we've had to like find really creative ways, but it honestly makes the job so much more fun because I like in adults, I'm pretty sure we're not making chocolate sundaes to get a child to poop.
I love that. And I feel like it shows to like as, the the feeding therapist that's working with the kids, like exactly why we should encourage more collaboration with pharmacists as well as being part of that interdisciplinary care team, because like I wouldn't know which ones would be okay. Like you said, like dairy, oftentimes you hear is like, okay, a lot of meds can't mix with dairy, but like sometimes they can, depending on which one it is and which like thickened liquid. I was thinking, Tova, when you brought that up right away, I immediately thought about the use of thickeners with laxatives, because a lot of times we have kids that need both, but you can't mix like Miralax, for example, with a commercial thickener, because a lot of times then it loses its thickness. It kind of takes away from, we're trying to make their swallow safer, but we also don't want them to be constipated. And then by mixing the two, it just doesn't work that way. And so we have to find other creative ways for it as well.
I feel like at the same token, like a pharmacist has no idea about like the consistencies, how the child is swallowing, like all of those like very important details. And if you think about how important swallowing is in your life, like you have to swallow your food, which is vital for living. You have to swallow your medications, which if you're a super chronic kid, also vital for living. But then you also have to swallow your saliva. So that's like another thing in the like in the hospital and in perfecting peds that I see is that a lot of these kids aren't able to like swallow their saliva. They're not able to swallow their meds. So then that just gets to the root cause of everything. Like this kid is having more seizures than he's aspirating because he can't swallow properly. So that's where we we call in our besties, our SLPs. And that's something that like I guess was ingrained to me so much in the hospital, like swallow study, swallow study, swallow study. So I'm always asking like, how is your child swallowing their medications? Do they need a feeding tube? Have they been assessed for a feeding tube? And that's just like the population that we deal with. Almost like the majority of them have swallowing issues.
Bree knows this about me, but when I get really excited, I'm like, I want to interrupt. Like, I want to interrupt and chime in. And like, the questions are just like piling on in my brain right now. I'm so excited. But she taught me how to like mute myself and be
I was like,
quiet.
Tova, mute yourself sometimes. just so that we can all get through. Because otherwise, I'm sure Mary, with like podcasts and stuff, it's like if we all try to talk at the same time, the recording is like nobody can actually hear what anyone said.
Wait, did I do it? Did I interrupt
No,
you?
you didn't. No,
Oh,
no, no,
good.
no.
Okay.
I'm
Oh,
just
time.
thinking
good.
about the conversation we had.
Yeah, yes. I'm my own worst critic, as I think a lot of us can say. But so when you were I have a list, but when you were talking before about how, most residents in medical school, they get one course in it, and even going to school to be a pharmacist, it reminded, and the research and how you have to extrapolate from adult literature, it reminded me so much of what we're doing as pediatric speech pathologists in the feeding world. We're extrapolating so much from the adult literature. A lot of times, I think it's changing. I really hope it's changing, but people have pediatric feeding as an elective, or when I teach dysphagia, it's half adult, half peds, because I want to give fair coverage to both, and there's only one course in all of graduate school for it. So I find that really interesting, and I feel like we could help elevate each other.
Yeah, that's so true. I think I do like to think that we're moving in the direction of more universities prioritizing having those courses, but I do know I feel like majority right now are still electives. There's some that have required, but majority is an elective. And then that's even like if you then were to get like a rotation with it, that's a whole nother layer to it as well. But like my dysphagia course was like a week or two of peds and the rest was all adult. But I think the research part, like we can definitely relate to that. It is very heavy in the adult population. But I think that's also where, like Mary, you were talking about, like that kind of is what makes it fun, is like how you have to problem solve through some of these things that like you're not going to see that in the literature, but it is kind of fun to be able to like take what we do have and be like, okay, now I have to think through this critically, and how does that actually apply to my patient. Like a lot of times the research, I find that like the method that they went about something is like, well, that won't work with a kid because they just won't do it. So like I see this outcome and that makes sense, but like I can't use that same method because the kid's just gonna not. So how do we come to that same result with using something similar but in a different way? And that's like one of my favorite things about pediatric feeding and swallowing, is because we are every single kid, we have to think through it like so critically because of that that.
I think an interesting layer with kids too is that you're not only dealing with the patient, but you're dealing with the caregiver too. So it's like a whole other layer. Like, I understand if it won't work for the kid, but it also has to work for the caregiver. So does it work with their work schedule? Are they able to do this? Are they able to somehow get their child medication in the middle of the school day? Like, does the nurse allow it? Like, what permissions do you need? So it's just like it adds a whole other layer. Like, you can't just be an adult with meds in your pocket. You have to go through nursing. The nurses have to be educated at the school, and the parent has to be able to like refill this. The pharmacy has to be able to split out the doses so there's home doses and school doses. So it adds a whole level of complication. And I think that it takes very special people to work in pediatrics. It takes like a lot of grit and creativity, and that's honestly why it's the best.
I would agree. I experienced it though, like I was mentioning my mom, and I feel like there are a lot of similar challenges with adults because Bree gets like long voice notes from me if I have a rant. And I was so ranty when she got home from the hospital a couple weeks ago because there were med errors. There were a few doses that were off. There was one medication that's over the counter. And so my dad looking at the list when you're talking about health literacy, he was like, oh, well, that's not important. But it was so important. We just didn't know. We just didn't know. And talk about health literacy, like I work in healthcare. I didn't know. I don't know about medications, especially for the adult population. So having someone like you is so, so valuable. And I was curious too, because you mentioned there's like, is it 1900 in the country, you said? So is that different than when you talk about board certified pharmacists? Like, I'm sorry, this is so ignorant, but like if I go to like Walgreens or CVS or Rite Aid or whatever, the pharmacist that's there, is that similar? Is that the same? That's different schooling or different? Okay.
It's different. So the pharmacist that usually you'll encounter like at a community pharmacy typically will do like the 4 years of like a bachelor's or 2 years. Some people don't get a bachelor's, they just do prereqs. Then they'll go to pharmacy school, which is like a doctorate. So that's 4 years that like non-negotiable you have to do. And then after that, you can go and work in a community pharmacy. So that those are the people like those are the kinds of pharmacists that you'll see outpatient. If you want to work in a hospital, then you would do residency. So it's 1 to 2 years in a hospital where you're just like straight up learning for 2 years. And then board certification is granted to you after 3 years of experience. So you're able to sit on the test after 3 years, but you have to like study and pass it, obviously, and then you have to maintain it. So you have to maintain all of your like education credits and everything every few years to keep that status. So your typical like retail pharmacist would just do the doctorate, like a hospital pharmacist would do like the 2 years of residency, but someone who's board certified had to like take another step. So the 1900 is just the count of the board certified pediatric pharmacists in the United States. I'm sure that there are more pediatric pharmacists, but I don't know how to count them. The only way we know is by looking up the board certification. And it's voluntary. It's not like for doctors, for like physicians, they have to be board certified in order to practice right now because I think clinical pharmacy is more of a newer field. It's like optional, but I see that in the future, they'll probably need to be board certified in something.
I can see the importance of something like that from like a regulation standpoint, from, making sure that like there's some, oh, what's the word I'm looking for? Like regulation is just popping up again, but like accountability to the education and the maintenance of it and all of those pieces together. And I think we see very similarly in our field in maintaining that licensure or certification to make sure that there is some consistency in what we're doing. So I think for a lot of the patients that we work with, where we see, at least for me, a lot of the breakdown is managing medications, specifically seizure medications for kids, and how that impacts like arousal. It can impact alertness, it can impact appetite, it can impact like, nausea, feelings of fatigue, and kind of all of those different pieces. And then additionally, you have the child who maybe has seizures who is also requiring thickened liquids and or tube feeds and kind of managing those pieces. So I would love to just kind of talk through like, I guess like I feel like so ignorant because I'm like, I don't even know what to ask, if that makes sense, you know? Like maybe we start out with like just part of that. So talking about seizure medications just in general in terms of like some of the side effects and how we can maybe, for example, I think of appetite as probably being one of the biggest ones, appetite and arousal being kind of the two biggest areas where I think about safety standpoint and how, you know, you would even potentially think through a case like that.
And I just want to
Usually,
add, one of the reasons why we were talking about this population so much is it's because one of the ones that we see the most variability and the most challenge when it comes to being medicated correctly and how much it impacts our ability to help.
Yeah, because it's a big risk to benefit populate, right? Like it's like, well, if we change this medication too much, we put the child at an increased risk of more seizure activity or that, you know, versus like, do we deal with the, okay, let's just come up with other ways to arouse them before a meal, like how to, anyway, it's a very nuanced conversation. Obviously, I'm not expecting you to have like, oh, well, this is what I would do with every single kid, you know?
I'm happy you asked me about seizure kits because that's honestly my bread and butter. My heart is in neurology, and that's like what I specialized in. So that's like the perfect question to ask. I think along the lines of appetite, there are a lot of seizure meds that do cause reduced appetite. So that's where it becomes a little tricky. So right off the top of my head, cannabidiol or Epidiolex is one of the ones which you'd be surprised because when you think of like marijuana, you would think that it would cause more of appetite stimulation, but because it's like the CBD part of it, it actually causes suppression. So a lot of kids, when they start Epidiolex, end up like being less hungry and they end up losing weight. The other one is topiramate or Topamax. That one definitely causes like weight loss as well, but then we kind of try to use it if the patient needs to lose weight. So you kind of try to double dip in that way. With the appetite, like it's kind of hard because the seizures or appetite, like what do you pick in this situation? And ethically, usually with appetite suppression, we would add on like something like cyproheptadine, something just like really benign that'll help them stimulate their appetite, or you can add on a seizure medication that will help, or if they have like additional psych problems, then like adding on an antipsychotic that stimulates appetite might help as well. So in those situations, I always weigh out the seizures first, just because like time is brain, the longer they're seizing, the worse it is for them. So we kind of just try to add on or double dip on different medications based on what their other conditions are. I'm a big like double dipper or triple dipper, quadruple dipper, whatever I can do. So like if the kid needs appetite stimulation, they also have migraines, delayed gastric emptying, and they need help with sleep. Cyproheptadine would be like my drug that could help with the appetite suppression, but then help with everything else. And that way we're only adding one instead of four to help with this problem. Along the lines of alertness, that's another really hard thing with these kids because if you like run any of their meds into a drug interaction checker, it's going to tell you CNS depressant all the way down. All these meds, unfortunately, are made to stop seizures and they're made to suppress the brain because a seizure essentially is like overactivity of the brain. So, one of the tactics I like to do with that, especially if they have the issue of insomnia, is doing larger doses towards the end of the day. So, we're so used to giving like the same dose. Like, let's say if a medication is given 3 times a day, you give the same dose normally 3 times a day, like 10 milligrams TID. Instead of doing it that way, a good tactic is to like gradually increase. So, let's say we'll do 2.5 in the morning, 5 in the middle of the day, and then 10 at night, and that way you're giving the same total daily dose, but then in a way that it forms more naturally to their body and like the sleep wake cycles, and then they'll be more alert during the day. I also will try to consolidate things as much as possible so that if it is something that can be given twice a day or once a day instead of like 3 times a day, if it is something that makes them sleepier in the beginning of the day, I'll try to just like give it at night if I can. So it's like a lot of just like playing with timing and like knowing the pharmacokinetics and the onset of things to make like the perfect custom schedule. I had a kid actually that was losing a lot of weight. He was a foster kid, just adorable, was losing a lot of weight, and the caregiver asked for like kind of an emergency meeting with me because she's like, yeah, he's not feeding, he's like very irritable, but then he's not sleeping at night because then he is so riled up in the middle of the day that he's not taking his nap, and it's like this whole slippery slope, and he's just not eating because during the day when he's supposed to be eating, he's like riled up trying to fight his nap. So then we changed his gabapentin, so it was like a low dose in the morning, so he'd be awake for his morning feedings, and then kind of a higher dose around nap time, so he'd get sleepy, wouldn't be riled up, would wake up for his like nighttime feeding, and then will be so tired by the end of the day that he'll get his like nighttime dose and fall asleep. So it's just a lot of just like communication and trying to find what fits best. And that's like something that we do at Perfecting Peds. We try to see the patient as a whole. So we're not just looking at like, do these medications work and like with the dosing and whatever, it's like, does it work with your life? Is our biggest thing.
I love that because I feel like as like in SLP, a lot of the times I'm thinking about, or when I'm collaborating with, like, for example, a dietitian, a lot of what we're doing with like tube feeds would be like timing, schedule, volume. Like, could we do less in the morning, more in the evening for catch up if we need to, and kind of modifying that. And it's the same thought process. You know, we don't think about that with medications because you're so right. Like, I feel like anytime I've ever been prescribed something, if they're like, take this 3 times a day, I automatically divide it equally 3 times, without even thinking about how, like, well, wait, it maybe doesn't have to be that way, depending on what the medication is. But also, I love that you talked about, like, doing like a two for a three for a four for, and kind of thinking about some of these medications of like what we may consider like a side effect in one kid could actually be a benefit in another, and thinking through like how we can, use one medication for a majority benefit. I love that.
Yeah, I'm always like a less is more kind of person. Like if I can reduce the amount of medications and reduce the amount of things you're doing throughout the day, because I can honestly tell you, I had to take a Medrol dose pack recently and I couldn't remember because it was like, take this one with this, and this, and it was like 7 times a day. When it's so complicated like that, like I'm a pharmacist, I know that I need to take it. I know like the reasons behind it, and I couldn't even take it. Like I try to just simplify it as much as possible.
I love it. I love the art of what you're talking about. It's like you're speaking our love language right now.
Yeah. I was
The
like, we go
art of
hand in
it.
hand.
Yes, the critical thinking and how it can become so siloed with medications, just like with dysphagia or pediatric feeding disorder. It can happen for so many different reasons. And sometimes we're operating with our tunnel vision instead of looking at the whole picture. And I'm just curious though, because usually if I think about, for example, like a reflux medication or motility or appetite stimulant, it's typically coming from a GI doctor, or if it's something like inhalers, pulm. So do you have any tips for us for how to open up dialogue with providers and pharmacy as a team?
Open communication. A lot, I can't say that it's always perfect because I do feel like sometimes people get offended, but I always try to frame things like a question and I try to make it like a conversation. So I'll be like, hey, what do you think about this? Like, how about we do this? So I try to do that and like form a relationship, but I can tell you that we're super open to like talking all the time. We love collaborating. I can't say that it's the same with everyone, but it just like trying and reaching out, I feel like doesn't hurt. Like the worst someone can tell you is no, but then you just try again with someone else.
I feel like it's honestly like, hopefully like listeners feel this way as well. Like, it's very refreshing to actually know that like we have another point of contact when talking about medications, because I totally like understand with a lot of the physicians that I work with, like they don't have time to sit down and have the conversation about like, hey, I'm noticing XYZ with their medications. They may prescribe the medication, but like we can still open up the conversation with the pharmacist on some of that as well. And so sometimes having more of like, I'm thinking about like if I was to call the GI, like Tova said, and to say like, hey, like, this, you're the prescribing provider. I wanted to bring up conversation. Like, what do you think about me having a conversation with the pharmacist about, managing the medication and the timing and the this and the that? And like, obviously one, like we ideally interdisciplinary, we want everybody on the team. We want everybody having this conversation, but also recognizing like where it might play a role, or who might play a better role in certain conversations. But I think that that could even like open it up more, because sometimes like at least I will find like it's so hard for me to get a hold of the physician. Sometimes I end up talking with like their nurse, or sending messages like back and forth, but like not as clear a line of communication as like going directly to the pharmacist and opening up that conversation there as well.
Yeah, and it's not really, it's like I feel like we're all equal in the fact that we all have our specialties, we all have things that we're experts about, so we should have mutual respect for everyone. So just like not really going to someone because you think that like the other person would respect them more, but just because maybe they have like an in with the office or something, or they figured out like the best way of communication. I think that like the respect should be equal upon everyone, but it's just knowing how to like work the system. We like love feedback and we love like learning from other disciplines what they think is best. So we do have like some physicians on staff with us that work as consultants, and they told us like a trick for you is that physicians love faxes, and faxes with check boxes. So if you ever have any questions, you can fax their office with like a checkbox yes or no and like a signature line. And honestly, from like a physician's perspective, they say that if they have like a busy day in the office, they'd rather have a stack of paper that they can check yes or no, give to their secretary, the secretary faxes it back, versus having to like type and respond to an email or a text or something. So just learning the best way of communicating, I think, will break down a lot of barriers. But then also just working and having like a team-based approach to communication, because sometimes it might be better to go on with something together, like, and be like, hey, we both think this, like, what do you think?
I'm thinking about aerodigestive patients where I have another baby right now where he's on a PPI, he was on Lasix, and he kind of outgrew the dosage. So he has breathing difficulties, was born premature. And it's like that would be the perfect scenario where it would be so helpful for GI and Palm and myself to and a pharmacist to meet together to talk about, well, this is what's impacting his swallow and his breathing and is this exacerbating his reflux. And there might be a way to consolidate or a way for us to help each other help him.
Yeah, I feel like there's so many, and like I guess being spoiled in the hospital where everyone's in one building, in outpatient, it's so different where you're trying to like get a hold of everyone, but then just having like a quick Teams call, like let's have a 5 minute powwow about this patient, I think would be nice to just bring everyone into the same room.
Yeah, absolutely. So, kind of shifting from like us reaching out and knowing, like, I'd love to talk more about like tips for to give caregivers on how they can best advocate or like questions they ask, because I feel like for me, a lot of this is helpful, right? Because it's like, well, I don't even know what I don't know. So, how do I ask the question? How do I frame the question? So, kind of just opening up tips for to share with caregivers about advocating for their child and questions to ask when they're maybe thinking about their medications for their child.
One of our caregivers actually, like, we had to, it was a hard sell for her. We had to, like, she was like, you have 5 minutes to prove yourselves to me. And it was kind of scary. She's like, I have three chronically ill children. Like, I don't have time for someone else at the table. Like, if you want to be a part of our care team, you have to prove yourself. So we were able to prove ourselves with one, and then she gave us all three, and she now actually works for us, and she's a patient caregiver ally. Love her to death. But the thing that she taught me and that sticks with me on a day-to-day basis is to stay curious. So just having that in your head as a caregiver and knowing that yeah, the doctor went to X school, the pharmacist went to X school, they have all these certifications. At the end of the day, they're still a human and they still should like be very curious and should be constantly learning. So just having that in the back of your mind to empower you to ask the questions. Nothing, no question's ever a stupid question. Like if you have a question if a med can be crushed and given via J tube, ask it. If you have questions about different interactions, if you have questions about something that you think might be better because you read about it or your SLP gave you a great tip about something and you just wanted to like check it out, ask. Like it doesn't hurt. And like empower yourself by asking, empower yourself by researching, like get a second opinion, get other opinions, reach out to other specialists. Like I think that medicine should be so fluid and it should be more of a conversation than an order, that you should never really be scared to ask.
And it's a team. So I love that you talk about empowering caregivers and also the curious, like for us as healthcare providers, as pharmacists, to be curious because they're the ones who are with their child who are going to notice the side effects or how it's helping or not helping, or when I give it at this time, it helps. What you talked about later in the day or earlier, vice versa. I'm noticing increased secretions or whatever it is that we're also listening to them as caregivers because they're the ones in the trenches who are going to have a lot more detailed information about how it's interacting.
Caregivers are honestly my favorite. Like I hate when they're dismissed in the hospital or they're dismissed in the clinic because they're seen as like the crazy mom who always has a million questions, who challenges everything. But that's the mom that cares. Like that's the mom you should be listening to. That's the mom that knows their child better than anyone else. They're in the trenches when nursing calls out, like they're the ones giving, administering, doing everything. So like that's the person you should be listening to. And like that's kind of the relationship that we try to build at Perfecting Peds. We try to make it so that we're not only a part of your care team, but we're like one of your best friends. So some of the moms, like I will see them and oh, they'll be like, "Can I call you for 5 minutes really quick to like run this by you? Because I just need to like say it out loud and like see if it's okay." And I'm like, "Sure." Like it always like stay humble and just like always be willing to like listen and bounce ideas back and forth because like what you think and what you learn in school might not always be what's best for the patient. It's just like communicating and like listening is I think one of the most important things.
Yeah, I feel like that and like the whole point of that, right? Like I'm the same way. I love the caregivers that are like, what about this? What about that? What about this? What about like constantly asking because ultimately like that like my main goal is to come up with something that is like functional for that specific family unit and like that child and that caregiver and trying to reduce any added burden as much as possible while still promoting progress of the child. And that open conversation is what leads to that. So like ultimately like those conversations answering those questions having caregivers, like any caregivers listening, ask those questions because ultimately, like that is what helps versus like I would rather you ask me so many questions than be like, okay, that sounds good, and it doesn't. And you go home and it didn't work and it's not working out for you. And then like compounding that versus just like the open dialogue of like, okay, here's one suggestion. And a lot of times, right, like I think, like you said, Mary, sometimes it's like it can come off as like an order and it's like, no, 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 this is not like this is a suggestion. It's a potential recommendation, but like you peel back the layers and you let me know what you think about that if it's going to work or not.
And if it doesn't work, call me and we'll troubleshoot it together.
Yeah.
I always try to empower and I try to give instructions. Like, let's say, like, you have the Senna and the Miralax. The child's having too much diarrhea, but still they're full of like stool. What do you do? And I try to teach them like too much diarrhea, so peel back on the Miralax. Too much cramping, peel back on the Senna. And we try to give them instructions where especially if it's over the counter things, not really so much with like prescription things. They know how to like titrate and they are able to like empower themselves to troubleshoot. But we always tell them like call us and we'll troubleshoot it together.
I love that. And even the fact that for caregivers to know that there are options, because it is one of those things where it can be, it's an order, it's a piece of paper and it has this specific, dosage on it. So even just for us to know that there's flexibility there, that there's room to make adjustments and that there are so many options is really powerful.
Yeah, absolutely.
I think the only other thing that I was curious about that I feel like comes up a lot, but it's not, complex and it's not always chronic, is reflux because I
Mhm.
feel like it's always changing how we treat it and how long we're giving certain
What
medication.
meds are best versus not.
Yeah,
Yeah.
and how certain reflux medications interact with thickened liquid, like if we're doing an MFMLAR, thickened formula, and how we have to be careful because it changes the efficacy. And I recently had a family ask about reflux medication, like, oh, we think it makes our baby nauseous, which our babies obviously they can't tell us with words, but they're thinking it makes their baby not feel good. So those are like when it comes to reflux, just getting your take on that.
With reflux, I'm in the camp of non-pharmacologic. I am like anyone will tell you that I'm the PPI police. I absolutely am very much against long-term PPI use because it's something that gets slapped on probably like from discharge from the NICU and then it stays on and then I see you when you're 21 and I'm just like, "Oh man, you've been on a PPI for like 20 something years." If you read the guidelines, PPIs are like drug of choice, but they should be used for a short amount of time, so like 6 to 8 weeks and then weaned off, just because of all the side effects. So there is like bone demineralization that can happen. One of my kids was on chronic PPIs and had like a fracture, so we had to like take him off of that. You also have like increased risk of infection. It depletes your like magnesium and B12. So I'm just not a fan of like being on something for so long that can be fixed with diet, medicine, like with diet as medicine instead. So I'm always in the camp of let's thicken, like let's try to thicken, let's try to elevate head of bed, like let's try to space out the hours between feeds and bedtime. So I try to really stray away from anything for reflux, but if they do need it, we try to do the lowest dose possible for the shortest amount of time possible. And then I always try to look for other causes as well, because a lot of times we think it's just reflux, but can it be solved via like a fundiplication? Can it be resolved somewhere else? Is it like another functional issue that's causing this? Like I like to get to the root cause of things instead of like slapping on a medication as like a band-aid for everything. So like even though I'm a pharmacist, I'm a big fan of like deprescribing and using like non-pharmacologic things because non-pharmacologic things have less of a propensity for like adverse effects. And I think like the more meds you slap on, the more chances you have of like drug interactions and different side effects that you may not want.
I love that. And I feel like it's so aligned with like the NAFGAN guidelines when they came out with, especially for infant reflux, and really saying like, hey, like let's start with like AR formulas or thickening feeds slightly so that we can see. And then, like you said, Mary, I have also found just like in my clinical practice that if a child has reflux, like after a year old, like still very significantly, or I'd even argue like significantly after 6 months old, there's usually something else causing it, like a food allergy or something esophageal, dysmotility. Like there's usually something else versus like that medication really making a significant difference. And I've had some kids that like the medication does help for that like short term, but ideally we want to have them weaning off of it as well so we can kind of reassess whether was a difference made or not.
And it goes back to like just staying curious and like wondering like what is it? Like can I continue to like look further? Are there more creative ways or more beneficial ways to fix this problem?
I love it. I want to jump through the screen and hug you.
I know I kind of want to I was like, "Oh, go visit Jenna's."
Yeah, so Jenna lives really nearby to me. Like I've run into her at the playground before with her kids. But I didn't even ask where you live.
I'm in Miami, so I'm yeah, pretty far away.
I feel like me and Bree should probably like post baby. Once
Yeah,
we have our baby, we should probably take a Miami trip.
yeah, we'll just go to Miami.
For sure. Come on down.
That's awesome. Well, thank you so much, Mary. I mean, we love what you all are doing at Perfecting Peds. I think it's really, really awesome. And I also love that like you all are starting to elevate the conversation as well of like pharmacists working together with feeding therapists so that we can really support continuity of care, improved, quality of care with the kids that we're working with because there are so many questions that we still need to be asking, and there's so many things that we can do if we just open up that dialogue and we start to open that up to really help kids and looking at them from that holistic lens.
Oh, thank you so much for having me. This is so fun.
We need to link in the show notes to all the information for how people can learn more about Perfecting Peds and how caregivers can use your service.
Mm-hmm.
I think a lot of people are going to want to
yeah,
know.
definitely. Like in the show notes, we'll have the link to your all's website and the podcast and your Instagram. Is there anything else we should add in there?
I think the website has like everything on it,
Perfect. So
but I can
like,
give you like a little blurb too.
okay, yeah, we'll add that in the show notes so that anyone listening can make sure to connect with you all. But yeah, thank you so much. We appreciate
And
it.
really come to Miami if you want. I was like,
Girls
I'm the
trip.
queen. I'm the queen of like free events and stuff. We have Art Basel coming up, so that should be really fun. Like all the magazines have like these parties, Chance the Rapper's performing, and like we
Oh
have the
my
invite
gosh,
for that, so it's free. So come on down, girls.
that sounds so fun.
Yeah. Anyone want to sponsor us to go to Miami?
Yeah, we'll
Can
do
we make
another
this work?
episode. We'll do it live.
Oh, thank you, Mary. You're so
Thank
awesome.
you, Mary.
Right, thank you. Have a great day.
You too. Bye.
Sure. Bye.